Hello, friends, and welcome back to my YouTube channel. And today we will discuss a very pertinent topic to our clinical practice. And this problem of patient desaturating on ventilator is we are facing on a daily basis. This I was prepared for a regional conference and I thought to share with you. The topic is my patient starts to desaturate on ventilator and how I'm going to approach it. So I will start with a case. A 50-year-old lady has a history of fever, burning sensation during micturition and frequency for last 5 days. Now come to ear with shock. Fluid resuscitation has been started, followed by vasopressors, and eventually the patient was shifted to ICU. We have started broad spectrum antibiotics, sent appropriate culture, urine and blood. We did a ABG and it shows severe metabolic acidosis. In view of worsening shock, two vasopressor requirement, and decrease in the urine output, patient got intubated. Now on day 2, the first scenario of patient desaturating on ventilator. There will be few scenarios which will eventually come during this discussion. The patient was severely hypotensive, in shock with very high vasopressor support. She was tachypneic, tachycardic, occasionally restless and difficult to manage with sedation. Patient was on ventilator with FR 2.4, minute ventilation 300 ml, PEEP 6, respiratory rate 20, I ratio 1:3. What on-duty resident did, he felt that the patient is moving, requiring so much sedation and causing hypotension. So let's paralyze the patient. And he eventually paralyzed the patient. And after some time, the patient started desaturating. So what happened exactly? We'll discuss in detail, but just give it a thought that a septic patient was hypotensive to vasopressor, probably have a minute ventilator requirement very high, maybe 15 to 20 liter. So his own respiratory rate will be around 35, 36, just to compensate for the metabolic acidosis that is happening by washing out of the CO2. Now, when you take those spontaneous respiratory effort out because of paralysis, obviously there will be gradual build-up on CO2. And in a closed space, the total pressure of all the gases we know are equal to the addition of all the components. Now here, if carbon dioxide partial pressure increases within the lung, there will be a definite drop in the partial pressure of oxygen and leading to hypoxia. This is called diffusion hypoxia, and we'll discuss this later in more detail, how to diagnose them. On day 4, this is a second scenario. We start to weaning of the patient. Patient was off vasopressor, urine output has picked up, renal function is improving, but suddenly patient start desaturating. Now what happened? We'll review this condition in more detail. When you're talking about desaturating on ventilator, so what is the exact cutoff below which it matters clinically? So most of the studies have shown that a saturation below 88 or a PO2 less than 60 is considered as a desaturating event and is clinically relevant. Some studies also shown that a drop in SaO2 by 3% is significant to call desaturation, acute desaturation. In a recent study called pilot trial, they compared target saturation of 90 versus 94 and 98 in a mechanically ventilated patient, and they found there is no benefit in terms of ventilator-free days and hospital mortality with a targeted higher saturation. But whether the lower saturation is more helpful, there are multiple studies which compare 88% saturation with 94%, like ROC-SISU trial, LOCO-REVER trial, ICONIC trial. In ROC-SISU trial, they compare conservative oxygen therapy around 90% with higher oxygenation, and they found there is no effect on 28 days ventilator-free days and 180 days mortality. Similarly, in LOCO-REVER study, they found no benefit of conservative oxygen strategy on 28-day mortality and 90-day survival. In ICONIC study, no benefit of low oxygen strategy compared to higher oxygen strategy in terms of 28-day mortality. So there is not much clinical relevance. Whether there is any practical relevance that we will see. So if my patient has a targeted saturation around 90, in the oxygen dissociation, PO2 oxygen dissociation curve, he will be sitting like here. Now, if the lung function deteriorates even a small amount, there will be a precipitous fall in the saturation because he is in the steep part of the oxygen dissociation curve. But on the other hand, if the partial pressure of oxygen is high because of supplemental oxygen and the patient is situated here, then even if there is a drop in saturation, drop in PO2 because of worsening lung function, there will be no drop in saturation. There is a plateau part. And the clinical decision making in terms of the worsening lung function will be delayed. The acute condition will be picked up pretty delayed. That's why there will be a blind spot to be created if you give an unnecessary oxygen and keep a higher PO2 beyond clinical requirement. By this method of keeping saturation around 90, you can use saturation or SpO2 as a very good respiratory monitoring tool. And what happens suddenly? My teacher used to say there is nothing happens suddenly. There have to be a pathophysiology that develops over time, and we have to pick it up early to intervene early and to get a best possible outcome. We are discussing this event, whether it is common. So there are very limited studies which look at the incidence. Mahmood et al. Had found that nearly 79 out of 955 ventilated patients, which is around 7 to 8%, has shown acute hypoxemia or desaturation while on ventilator. And the etiologies we all are aware, very common causes like pulmonary edema, atelectasis, pneumothorax, pneumonia, ARDS, endotracheal intubation, tube ventilatory malformation, airway bleeding, and pulmonary embolism. Similarly, Marin have found nearly 30% of those patients has multiple episodes of desaturation while on ventilator. And he found most common cause was a winning trap. We know there is this entity called winning associated pulmonary edema because of increase in the preload and afterload due to change in the ventilatory setting from a control mode to pressure support mode. There are other etiologies he has found like atelectasis or secretion retention, pulmonary edema, fever or surge because that will increase oxygen consumption and can cause a relative desaturation or increase in oxygen requirement. There can be occlusion or displacement of the endotracheal tube, patient ventilator desynchrony, bronchospasm, patient transfer, during patient transfer, and pneumothorax. The first thing what we have to check that whether this drop in saturation is spurious or it's real. As you compare to the graph A, where there you can get a good plethysmographic signal, graph B show poor signal, suggestive of a low perfusion, and C and D are showing different kinds of artifact because of noise and motion. So even if the saturation, whatever the number is showing on the monitor, if you get a graph like this, you're not able to interpret it. You have to reposition your probe to get a proper plethysmographic waveform. Then you can act on the number coming along with it. And if the patient is desaturating, so we have to intervene to have a symptomatic improvement that we have to give supplemental increase in the supplemental oxygen or PEEP or the change in the interface in terms of ventilation. And at the same time, we have to also work on the etiology, the cause to halt the progression of the pathophysiology. So both interventions need to be done together at same time. And to address the different etiology, we have to understand something called oxygen cascade. It is the transfer of oxygen from the atmosphere up to the cellular level. And during this journey, oxygen transfer from atmosphere to the lung via airway, go to blood, then carried by the blood to the tissue and has been utilized at the end. So if there is a pathology at any level in terms of up to hemoglobin saturation, patient may present with the desaturating episodes and we have to identify the cause. But all causes are not life-threatening. Some causes may lead to very rapid deterioration and may cause death. So those we have to address early. You can remember them with a mnemonic called DOPES. D for displacement of the endotracheal tube, O for obstruction of the ET tube. P is a patient-related factor like pneumothorax, which is most important. It's a tension pneumothorax leading to hemodynamic instability. Or it can be pulmonary embolism, pulmonary edema, collapsed lung, or bronchospasm. There can be equipment failure related to ventilator that we have to identify early. And there can be stacked breath, which can happen because of bronchospasm and faulty ventilator setting. So whenever there is a desaturating episode, we have to differentiate between the man and the machine. So take the patient off the ventilator, take the patient on the AMBU by disconnecting it, give 100% oxygen with a bag mask do gentle bagging. At the same time, you can do a test lung. Use a test lung to check for ventilator malfunction or or how the ventilator is working at its end. When you're looking at the patient, there are protocolized approach called MASH approach, where we look at the underlying pathology in the patient. So we look for movement of the chest during ventilation, whether it is absent or is movement only on one side. If the chest is hyper expanded, suggestive of a pneumothorax. Whether there is a drop in the saturation SaO2 of the blood and PaO2. So if we'll do an ABG and if there is a difference between SaO2 and SpO2, it will strongly suggestive of a hemoglobinopathy. And in an acute context, mostly it will be methemoglobinemia precipitated by certain drugs. And it can be confirmed or more suggestive information will come by looking at the skin color of the patient, whether it is turning blue or pinkish. And we need to remember that change in SaO2 will lags behind the change in the true oxygen saturation. And the last is the hemodynamic instability. Because if the patient is hemodynamically stable, the pathology is probably pulmonary. If the patient is unstable, then probably it's a cardiorespiratory failure, including the cardiac dysfunction. But mostly these hypoxic episodes are transient and they resolve very rapidly. In that situation, if you're not able to identify any definitive immediate cause, the patient recover very fast, you have to look for some simple intervention that can cause sudden disability. Like whether there has been an immediate suction has been done, followed by inadequate oxygenation, whether the patient's ventilatory circuit got disconnected unintentionally, whether there's any problem with the ventilatory setting or equipment failure. Further, you have to check for ventilator setting immediately and some do troubleshooting as I already discussed. Now, when you are trying to ventilate the bag, it can be very easy. That means there is inadequate resistance in front of it. It can happen because of circuit leak, because of cuff leak, disconnection of the tube, or a hole, or the mask, or a hole in the circuit. Or there can be a dislodgement of the endotracheal tube. If the patient is on ventilator, what we can see a certain amount of leak. Though if the ventilator tube is disconnected, the amount of leak will be very, very high or significant compared to this amount that is showing in this graph. Now, on the other hand, if the patient becomes difficult to ventilate, then you have to identify whether the problem is at the endotracheal tube level or at the patient level. If the tube gets dislodged and go to the esophagus, we have to check for EtCO2. Tube can be blocked. To confirm it, we have to pass a suction catheter or a bougie through it and watch for resistance. There can be endobronchial intubation that can be identified with an auscultation by chest X-ray or an ultrasound. And even if after all this intervention you have doubt, standard recommendation is to remove the tube and put it again with a new one. To identify a displaced ET tube, whether it's trachea or outside, is pretty challenging with an X-ray. Because even if the tube is in the esophagus, it can overlap with the shadow of the trachea. It can be confirmed with a lateral X-ray, but we know that we are not practicing lateral X-ray in our clinical practice. But it can be confirmed easily with an ultrasound. That's why all intensivists should be familiar with the basic ultrasound that need to be done in your ICU practice. Here you can clearly see with the movement of the tube, there is an undulation happening within the trachea. That means the tube is in the trachea. That much we are aware, we are sure about it. So if it is not within the trachea, what will happen? Compared to this double line sign or double tube sign within the trachea, you will get another shadow which is outside the trachea, just lateral or medial and behind, which is the standard position of the esophagus. So that ensures that tube is in the esophagus. So after that, when you identify the problem is with the patient and tube issues have been ruled out, we have to check for reasonable chest movement. So it can be unilateral abnormality or a bilateral pathology. In unilateral abnormality will be pneumothorax or lung collapse. Here you can see the one side is moving and another side is not moving. In bilateral pathology, whatever the chest movement is there will be equally distributed on the both sides. And the cause can be pulmonary edema, bronchospasm, chest pulse movement will be minimum for hyperinflated lung and can be pulmonary embolism. This part we have already discussed a bit during our initial hypoventilatory phase. Similarly, whenever there is a lung pathology, we have to see whether this desaturation is because of a increased partial pressure of carbon dioxide within the lung or because of a abnormality in the gas exchange barrier or membrane within the lung. And that can be identified by something called AADO2 gap. Here, the idea is if there is a abnormality in the membrane, then AADO2 gap will increase. Normal value of AADO2 gap, that is the alveolar arterial oxygen gradient gap, is 5 to 25 in a young patient without oxygen. Now, if it goes up, it indicates shunting or VQ mismatch, and if it is normal, that indicates diffusion hypoxia. And cause of hypoxia is probably increase in the other gas, that is carbon dioxide. Next, if the tube is in the endobronchus, yes, it can be identified easily because of the anatomical dislocation and the position of the right-sided mainstem bronchus. Mostly the endotracheal intubation happens on the right side, and there will be a concomitant collapse of the left lung. It can be confirmed in the ultrasound also. Here, what will happen in the left side? Because of no ventilation, there will be pleural sliding absent compared to the right side. Left side pleura is have a jerky movement, but that's not sliding. This, this is called lung pulse, and you can see the rate of movement is very high, not collaborative with the respiratory rate, but nearly as good as high as heart rate. And there is a pattern till the lung air get absorbed and lung become solidified or totally collapsed. So this indicates a right-sided endobronchial intubation. Now, pneumothorax can be easily identified from a chest X-ray like this one, or there can be a atypical finding which is common in case of anterior-posterior chest X-ray, in which we do in ICU, which is called deep sulcus. You can see a gap of air, that is a small line of air between the thoracic cavity and the chest wall part of the diaphragm, costophrenic angle. And this is because of the positioning of the patient and the X-ray that has been done in anterior-posterior view. You can also confirm a pneumothorax in ultrasound. There will be absent lung sliding, stratosphere sign or a mode in if I put a cursor through it, there will be lung pulse will be absent because of the air. Cardiac pulsation cannot reach up to the pleura. B lines will be absent because lung is not there. So no posture of deaeration. A line will be present because there is air, though it is not within the lung. And if you are lucky, you can get a lung point. What is lung point? It is the transition point between the mobile and the immobile lung. That is the point where the parietal and the visceral pleura got separated. And it is a very pathognomonic of pneumothorax in our clinical practice. If along with pneumothorax there is a subcutaneous emphysema, we will get something called E lines. These are vertical laser-like lines. It's quite similar to B line. Difference is that they does not reach up to the edge of the skin. They arise from the skin and not from the pleural line. And you cannot see anything beyond it because of the artifact generation. There can be pulmonary edema leads to hypoxic episode. In X-ray, you can see bilateral downglassing, haziness, maybe perihilar, but it is difficult to confirm whether this is cardiogenic or non-cardiogenic. With an ultrasound, it is much more easier. You can get a cardiogenic pulmonary edema where the distribution of B lines will be homogeneous on both sides. It will be gravitational distribution. That means the upper part will have less B lines compared to the base, and the pleural line will be smooth because there is no lung pathology like here. On the other hand, if this is a pulmonary cause of ARDS or hypoxia, or patient has a pulmonary cause pathology for this development of pulmonary edema, then you'll get non-homogeneous distribution of B lines, non-gravitational distribution of B lines, irregular pleural line like this because of something called subpleural consolidation. Because of this is solidified, ultrasound can pass easily, and followed by when there is some error, they start developing B lines. So this is suggestive, more of a suggestive of a pulmonary cause of hypoxic respiratory failure. There can be underlying pneumonia. It can be confirmed by an dynamic air bronchogram with an ultrasound that may lead to a desaturating episodes. Now we somehow survived with our interventions, and by day 5, the third event happened. Patient was persistently hypoxic, did not recover very well. He was sedated, paralyzed. So we have to decide between recruitment and pruning. So we decide to recruit the patient with a high PEEP, followed by a high PEEP. There was an immediate improvement in oxygenation with a PEEP of 16 or 18. And what we found that after that, there is a hypotension followed by hypoxemia. We are aware that during high PEEP, there can be some amount of hypotension because of decrease in preload. So we didn't bother. We start some vasopressin. Cardiac output monitor was there. So we connected with it and checked for a volume response to give further volume. Cardiac output monitor showed there's a significant respiratory variation with the SVV and PPV, more than 20%. So we start giving fluid bolus. What we found with more fluid bolus, patient is becoming more hypotensive and start desaturating more. So exactly what happened? My cardiac output monitor was saying to give more fluid. But we need to remember this SVV PPV does not work if there is a right-sided dysfunction, right-sided cardiac dysfunction. And exactly in this patient, because of recruitment and high PEEP, this patient develop an acute cor pulmonary. So what to do? We have to go for an echo, and we found there is a acute dilatation of the RARV, and there is a significant decrease in TRAPC, that is tricuspid annular plane systolic excursion, that indicate the systolic function of the right ventricle, mainly at the base. At the same time, we can look for tricuspid regurgitation and the peak tricuspid velocity to calculate eventually the pulmonary artery pressure. Now, what if my patient has a normal ejection fraction, a normal right-sided cardiac output? To measure with an echo, it found that PA pressure is 70. What next? What can be the underlying pathology? So, because of this high pressure, there can be a shunting of blood from the right side to left side because of patent foramen. This we need to identify if there is a normal cardiac output with desaturation. This desaturation is happening because of something called venous admixture. And to confirm the diagnosis, we have to do a bubble echo, where the bubbles, air bubbles created by creating an agitated saline is injected into the right side of the heart, and we will found within 1 to 2 cardiac episodes, these bubbles will come to the left side of the heart. That indicates there is a shunting at the cardiac level. It is, if it happens from 4 to 8, it's an extra cardiac shunting, and if it is beyond that, there may be a pulmonary shunting or a normal pathology. So to conclude, desaturation on ventilator is common. There are some common and predictable emergency, so we should have a structured protocol. Maintaining adequate oxygenation is the key. First step to differentiate between the man and the machine, and to take off the machine-related problem by control on the ventilation. And the pathology can be in the airway, lung, and heart, and accordingly, we have to address it. So by this, I like to conclude my presentation. Thank you for joining us.